Hi, I'm Tammy Potter, and welcome to the Pregnancy Process Podcast, a show designed to help you navigate the hugely transformative journey to motherhood, where you'll hear the unique experience of experts in this area and the incredible stories of women sharing their conception, pregnancy, and postnatal journeys so that you can have a healthier, more informed pregnancy. And in today's episode, I speak to Dr. Angela James. Angela is a specialist pelvic health physiotherapist with over 20 years' experience in managing complex pelvic issues for both men and women. She is the founder of Sydney Pelvic Clinic and holds a specialist title from the Australian College of Physiotherapy in recognition of her clinical achievements. She is a casual lecturer at the University of Melbourne, where she runs masterclasses for pelvic girdle pain. She also runs courses locally and internationally for practitioners on the pregnant pelvis, coccyx and perianal pain, and pelvic organ prolapse. Angela specialises in complex pelvic pain, bladder and bowel dysfunction, pelvic girdle pain, and pelvic organ prolapse, among other areas. And in today's episode, we're going to talk about why women do better with their pregnancy, birth, and postnatal recovery when they know more, when they feel empowered with knowledge and skills to make informed choices. We'll talk about how you can prepare your body and mind to feel ready to face the challenge of birth and recovery, and how training, preparation, and a positive mindset can change the experience. And before we dive in, I really want to say, as a pregnancy and postnatal specialist strength coach, I am truly passionate about the support and services that Angela provides. And I believe that every coach who works with women during this unique stage of their lives needs to have access to and support from women's or pelvic health specialist physiotherapists. Personally, I've had the pleasure of working with Angela for close to a decade now. I've been fortunate enough to attend some of her practitioner courses, and honestly, I don't believe I'd be half the coach that I am today without the support and guidance that I've received personally over my career from Angela herself. And I know that we both have similar goals in ensuring the women whose lives we touch don't turn around and say, I wish I'd known that before. And this is one of the driving forces in everything that I do here at the pregnancy process. So Angela, thank you so much for your time today. It is fantastic to have you with us.
Oh, thank you so much for having me. I'm very excited to chat with you.
I know, so am I. And if it's okay with you, I'd really like to start with the specialist title that I know we're going to focus a lot more on like pregnancy and postnatal and the pelvis and all that type of thing. But, you know, you did recently receive a title that only 2 people in New South Wales have ever received before. And, you know, I've personally worked with many physios over the years, and not a single one of them held a doctorate. So is it okay to tell me a little bit about that and start with that?
Yeah, sure. Yes, it was a big moment to get through the training program. So it's the pinnacle of a clinical physiotherapist kind of career to meet the requirements to pass the rigorous test at the end. And physio is sort of setting up to have different streams of special interest. So most people know musculoskeletal physio and sports physio, and there's pain and cardiopulmonary and all sorts of different components to physiotherapy. And the women's men's pelvic health specialty has been around for, oh goodness, not as long as the others. So maybe 10, 12 years, something like that. So it's a relatively new component to physio, and there's not many of us. So there's 14, I think, in all of Australia, and now 2 in New South Wales. And really, in your career, you make a decision about which area you want to be in, and then if you want to be academic or a clinician. And I'm very much a clinician at heart. It's my passion to be the very best pelvic health physio I can be. And I really hold that close to my heart, with wanting to be very much on top of the evidence-based and aligned to best practice. So I've always been someone that's looked to do the very best training to support that goal, to be aligned to that goal. And so taking on the specialist pathway just made a lot of sense to me. And yeah, I've spent the last 3 years focusing on that, which was big and busy, but ultimately very rewarding. And yeah, luckily I got through the exam at the end of last year, and then I was awarded with a clinical doctorate to be recognised as a specialist in my field. So yeah, I'm very proud of it, worked very hard for it. And I really feel that to be, yeah, the very best version of yourself as a clinician, they're doing the pathways that support that, such as the masters or in this case, the specialist pathway is sort of just part of that journey.
Amazing. I mean, congratulations. It's such a huge achievement, especially considering all of the other hats that you wear at the same time. So
Yeah.
I just want to say congratulations
Thank
on
you,
that.
Debbie.
Like, it's
Thank
really
you.
amazing. And, I feel like there are so many areas that we can talk about, and it's almost too hard to choose a place to start, but I think when it comes to the pregnancy process, the maternal metamorphosis, so to speak, I mean, you can't really get past the fact that it's broken into a few distinct phases. You've got the conception journey, you've got the pregnancy, you've got the birth, and then you've got the postnatal recovery journey, right? And each phase is totally unique and requires different knowledge and different care at different stages. And from my knowledge of what you do, you can actually help with every area, even helping women suffering from pelvic issues surrounding fertility, like endometriosis. And in terms of that, where would you like to start? Would you like to start at the conception journey or the pregnancy journey?
Oh goodness, I don't mind.
Mhm.
Wherever you choose to start, I'm happy to go there.
Okay, great. Well, I mean, let's start with pregnancy.
Okay, great.
And you just mentioned evidence-based,
Yeah.
and there's actually some recent research around the intensity that women can work in during pregnancy. It's the first study that they've kind of done on this, about the intensity that women can work to, being up to 90%, I think it was, off the top of my head. And I'm yet to share my own thoughts on this. I certainly have them. And as someone that's worked with women during the stage of their lives and seen every facet of it, I'd really love to start with your perspective on this.
Yeah. So historically, women used to be treated like they were fragile when they were pregnant. So, don't move, don't put your hands above your head. The umbilical cord might strangulate your baby if you put the washing out with your hands above your head. Just, put your feet up and rest. You're pregnant. So that was the kind of construct that we were working under for like a long time historically. And, research is great because it debunks a lot of these myths. And what's happened over the last, 15 to 20 years is we've really come full circle away from that idea that not only is it safe, but it's really important for women to be exercising for every health benefit, unless there's some medical reason that prevents them gaining those benefits. So there are some contraindications, like preeclampsia or like an incompetent cervix, which is not a great term. I wish that would change, but there are some things that do prevent women getting the benefits of exercise. And it's not actually just for women, it's actually for their babies as well. So we also know that the benefits of exercise go through to the baby. So they have a lower heart rate, they have a better birth outcome. So it's absolutely positive for woman and child. And in terms of the actual guidelines around heart rate intensity and the environment, in terms of the temperature, I actually don't think we're there yet with knowing exactly what's what. I think that the evidence isn't conclusive. So I think where we are with the evidence base is that we're very, very clear that exercise is important for every facet, unless you have a contraindication. It's looking like less restrictions are required and more freedom should be given. And what the top end intensity, maybe there's not one rule fits all, and maybe it's more to do with what the woman has done beforehand and what her body's adapted to. It certainly probably isn't a time to like go from not much to like super high intensity, which we know that that's not the case for anyone. A slow progressive model is the way to go, 10% per week for most things, re-injury risk. But I don't know if there's going to be a blanket rule for pregnancy. I think it's going to be less restrictive, very positive messages around exercise for mum and child, and then there'll be an individual kind of prescription depending on, you know, the history and the individual that you're training and encouraging to move. But definitely strong messages around how important exercise is for mum and baby.
I like that. I mean, I'm a very much individualized approach. Everything that I do is very individualized, and that's what a lot of my messaging is around. I'm yet to share my views on this, and I probably don't want to sidetrack this conversation down that path. So I definitely agree with the individualization there. And I really like the 10% per week kind of progressive model that you just suggested. So I think that's a really, really great takeaway from that, you know, you're not, during pregnancy, you're not going to go from 0 to 90% the minute that you step into the gym, you know, or even in 9 weeks, you know. So I think that's a very, very good takeaway from that. And I think, you know, when it comes to pregnancy, and especially, you know, based on what you do, we can't get around the pelvic floor and abdominal separation. So can we talk a little bit about the role of the pelvic floor and the changes that it needs to go through during pregnancy and the birth?
It's like the Olympic Games for the pelvic floor. So with the recommendations at the moment as they stand, most international guidelines for exercise show that, you know, to get minimum benefits for all the health systems, it's 150 minutes or 150 to 300 minutes of moderate intense exercise. And that's all your cardiovascular stuff. And then 2 resistance trainings per week, plus something to do with your pelvic floor. So they're the kind of 3 pillars of exercise therapy for pregnancy, which is probably similar to most guidelines for most other things. And then, as you say, tailoring to the individual person, goals, history, and health status from there. And then the pelvic floor, again, like, you know, that idea of tailoring, because we know that to get the benefits of reduced risk for urinary incontinence, which is real. So if you do strength-based training for in pregnancy, we know that women get a 30% reduction in the chances of urinary incontinence, right? And that's great. Like if I knew nothing and someone told me that, I would definitely be doing my pelvic floor exercises in pregnancy. And there is a way to do that properly. Like it has to be strength-based. So you have to have a certain level of intensity with your contraction. You have to hold for a certain amount of time. You have to do a certain amount of reps, just like you'd approach your strength training. And not everyone can do that initially. So you can't put a blanket prescription and expect everyone to do it. And a lot of people don't even do the exercises properly. They're squeezing their glutes or their jaw or their abdominals or everything but. So, and then you've got a different category of people that have a history of, like, say, endometriosis or sexual pain or even hip pain, and they have a pattern of overactivity. And we've had patients that have had so much overactivity in their pelvic floor that they've actually got like voiding dysfunction, which means they can't empty their bladders effectively because their pelvic floor is so tight. So that's why, again, that idea of tailoring to the individual and doing an assessment to know what's going on in their pelvic floor and then lead them towards best practice is just so important. So that's the overall kind of, you know, way to approach it in pregnancy. There's a lot of load. So from the weight of the placenta, the weight of the baby, the increased blood, the increased boob size, the increased body weight, the changes in the pelvic girdle. So there's a lot of different kind of factors that mean that the pelvic floor needs to be even stronger in pregnancy. So it really is like the Olympic Games. So we need it to really hold its function and to make us not leak and not have prolapse and to be able to do all the right things in and around our pelvic girdle. But then at the end of pregnancy, we want it to be completely different in its function. And we know that for a normal vaginal delivery, we need that pelvic floor to stretch 3 times beyond its normal resting length. And that's actually equivalent for me, who doesn't have, I have normal flexibility in my hamstrings, but not ultra flexible. Putting my heel behind my head, it's like I couldn't do it. But that's what we need in our pelvic floor during birth, and it's possible because of like hormones, and there's lots of soft tissue between the connective tissue and smooth muscle that makes it possible, and labor hopefully is slow and sustained over time. So there's certain things that make that sort of Olympic game moment possible and achievable. But it's really important that people understand that there's a change in focus for birth, and it's not the same as pregnancy, and it's not the same as postnatal recovery. We really need to work on lengthening and relaxing and having an effective push strategy. So, for example, in birth, and say we're second stage and we need to create a little bit of downward pressure to get the baby through the birth canal, if our pelvic floor has a paradoxical contraction, which happens in some women, is that our uterus is pushing our baby down and our pelvic floor is going, no, and it holds it back. And that is the wrong time to find out that that's what your pelvic floor does in that moment. So I'm a really big advocate of birth preparation to sort that out and get the pelvic floor understanding what it means to stretch and relax with intense pressure. And then, of course, on the other side, once the baby's out, we absolutely want to go back and like the idea of closing down that portal and reducing the length in our pelvic floor, so that our organs and our bladder and our bowel and our uterus and our cervix all stay inside our body, and the pelvic floor can provide support to keep us continent, so keep like pee and poo inside. And when we have symptoms where we're leaking from the back passage or the bladder, or we're feeling heavy or bulgy, they're all signs that the pelvic floor hasn't sort of regained its function and it's not holding that portal closed. So it is complex, and I think that's why I'm so passionate about people linking into pelvic health physios, so they can kind of understand what their pelvic floor has done prior to being pregnant, to optimize it for pregnancy, to know then it changes for birth, and then to recover. And so on the other side of that journey, they're fit, functional, and happy with the things that they're doing with their body, and they're not being held back by these pesky symptoms that are so common but not normal. Like 1 in 3 urinary incontinence, 1 in 2 after a vaginal birth will have some level of prolapse. 1 in 10 have fecal incontinence. So they're not uncommon symptoms, but a lot of the time, if we manage things better, they don't have to be there. So yeah, that's the pelvic floor.
Yeah, wow. I mean, 1 in 2 of prolapse.
Some degree of prolapse.
Yeah.
Yep, that's right. So that doesn't mean that everyone's feeling a bulge and heaviness, but 1 in 2 women will have some change in the mobility of their pelvic organs. So say if you've got that and you're not symptomatic and you don't know that it's there, and then you go and do something really heavy, like it could just be one thing, like picking up something that's too heavy for your pelvic floor, and then boom, you feel it. And say then they come into the clinic and they say, I've got this sensation, and we're like, oh, so we've got to train the pelvic floor. And that's the first time they've heard about the pelvic floor. They get really annoyed because they're like, well, if people know that that's what happens, and people know I'm a little bit at risk, why doesn't anyone say anything? Yeah. So that's what we want to change. So we don't have so many women, which we used to have much more women say this, but I think we're doing better jobs at preventative healthcare now. Why didn't anyone tell me that?
Absolutely. And, I've spoken to a woman recently she's one of your clients, I think,
Ah.
recently on here, and she was, why I wish someone had told me that before. So, and I know one of your big driving factors in doing what you do, and one of the huge driving factors in me doing what I do, is to make sure that any women that we come in contact with don't turn around and say, I wish I knew that before, or I wish someone had told me that. So
Absolutely.
So, and there's another thing that I think is quite prevalent, especially during pregnancy, when it comes to the I wish I'd known that before. And I might just back this up with a little story of a client of mine who, when she was pregnant with her first child, had abdominal separation, didn't actually know what it was, and would see the kind of Tobleroning out through her abdominals and think nothing of it, and actually think that it was her baby's spine. So every time that it would happen, or it was almost like, like cute, like, if you know what I mean. So there was that lack of knowledge, understanding, and education around what was actually occurring with her abdominals. So can we speak a little bit around abdominal separation and, what abdominal separation is and why there should be a focus around minimizing it during pregnancy and how we can go about doing that?
Yeah, so it makes sense that this happens. So, the rectus abdominis, which is the six-pack muscle, goes from the rib cage down to the pubic bone. And it's two lines of muscles with three separate parts, which is like the six-pack, and then it's met in the middle with a connective tissue, so the linea alba. And that stretches in pregnancy. And so if it just stretches, there's no interruption to the connective tissue or the muscles. However, with most people, so the percentage or the prevalence of diastasis is like 90+% in pregnancy, but the degree of it is different. So it could just be muscle stretch, and then it could be linea alba separate, like stretch and not necessarily tearing. But then for some women, the connective tissue actually tears, and there's quite a gap and an interruption. This is where the problem is there's an interruption in how you transfer loads from one side of your abdominal wall to the other if that connective tissue is too interrupted. So that's kind of the challenge, because it's normal in pregnancy. It kind of has to happen, but the degree of how much it happens is different for everyone. And there's a lot of variables that go into that: baby size, mother's torso, connective tissue, position of the baby, lots of different things. And the research sort of looked at this over time because, rehab was focused initially on closing the gap. And most people have a sense, okay, if I've got a gap, I want to close it. And what is, I guess, a gap that's not acceptable and probably thought to be around 2 centimeters. Like 2 centimeters is probably thought to be something not so good for the abdominal wall function. But it's not all about the gap. It's the function of what happens in that connective tissue that connects the two sides. So we're really looking at improving the ability of the abdominal wall to transfer loads from one side to the other. And that more means improving the function of the deep core and the connective tissue. And in some cases, that may mean a slight widening to get that done well. So there's a bit of nuance in terms of the rehab. But ultimately, that's what the focus is improving the ability of the abdominal wall to transfer loads effectively. And we know in pregnancy that we don't want to be doing exercises that promote the obvious doming and poor function or transfer of loads in that area. So I guess that's the roundabout story that for rectus diastasis, and there's more research going on as we speak. You know, for example, there was something that came out recently because, you know, things go in roundabouts, but sit-ups used to be the main thing. So they used to have this technique where they wrapped a woman with a towel and like brought her abdominal wall together and did like hundreds of sit-ups. And that was shown to not be so good for other reasons, because if she's got a really weak pelvic floor and doing like hundreds of sit-ups, that may, you know, not be good for things like prolapse and urinary incontinence. But then a recent study has shown that with good technique, so with good pelvic floor technique and adding sit-ups in, it's actually really effective in shortening the rectus, which is part of what you're trying to achieve postpartum.
That's just so I can clarify here, what you're talking about is during the postpartum period,
Yeah,
and, and shortening the abdominal set of stretched, you know, like and would potentially be like corrugated iron. I remember this. That's bringing them back to their original kind of length, and it's definitely not during pregnancy.
No,
Okay,
no, definitely not in pregnancy. But yeah, so I think probably the point is that the research is still happening around what's best to do. But I think the overall framework is improved function. And it's not necessarily all about closing the gap, but it's about improving functionality. Sit-ups is probably not as bad as what people may think, but in the right dosage at the right time with the right technique, in combination with whole body, you know, more functional training. So because it is lengthened, it does need to be shortened. It's probably the one time that it kind of makes a bit more sense to do it, as long as they've got good pelvic floor and it's not the only way that you're training the abdominal wall. So yeah.
Amazing. So I guess that would go, and I've still got loads of questions about pregnancy, but seeing we're veering down this path, that would probably go, you know, the research around sit-ups in the postpartum, that would probably go almost hand in hand with the research about how smaller jumps and small plyometrics can potentially be beneficial for the pelvic floor when it comes to strengthening postnatally as well.
Yeah, so that's right. So pelvic floor has a reflexive activation. So they've shown that, say, with running, just before you put your weight through your body on heel strike, that your pelvic floor is having like a supermax contraction to try and stabilize your urethra and keep you dry. So that theory goes into doing some sort of plyometric training, like, you know, heels up and then dropping your heels down with or without a conscious pelvic floor contraction. And I think where to work out to make it conscious or not is really dependent on the person. So if you have a very weak pelvic floor and it's not having reflexive contraction, so say, for example, we test that and we say, okay, now cough, and there's no pelvic floor contraction, that's a sort of person that we'd want to actually consciously turn the pelvic floor on before they drop their heels down and get that kind of reflexive activation pattern happening. But if they're really normal, or if they've had a cesarean section and there's no pelvic floor symptoms or weakness, then they probably don't necessarily need to do conscious activation. So it really does depend. But yes, that idea of adding some plyometric and dynamic to stimulate what is typically a normal reflexive pattern can actually generate really good pelvic floor muscle training and function. So running is, again, one of those things. It's not as bad as what people think, providing that you've done all the things around to make the system nice and steady and robust and ready for the loads of running.
Absolutely. It comes back to that individualization again. I think that's really interesting, the point that you made about the stretched connective tissue and how there's varying degrees of abdominal separation, or and it's interesting with all of the different women that I train, you know, you can see the separation. So it's really good to have an understanding around the fact that it could just be the actual abdominals separating, or stretching. It could be the stretch of the connective tissue. Just because you can see a little bit of that happening, it doesn't mean that the actual connective tissue itself has torn.
That's right.
So I really love that there's those layers, the nuance to it, you know. So while, you know, they may be they may be worried about it, it might not mean that their connective tissue is actually torn. And if we maintain that connection to it and make sure that they're breathing correctly and the function of their abdominal wall is correct during pregnancy, then it may not actually be as bad postnatally.
Yeah, that's right. And I mean, if you ever, like, if they wanted to know more, you'd go for an assessment. And one of the main things with your assessment is the depth. So, you know, patients that have separation, that if you put your fingertips in the gap and there's not a lot of movement, or there's a little bit of movement, but you don't feel like you can reach down towards their organs, then they're okay, you know, and you train them with the right function and you move them forward. The ones you want to catch, the little red flags, are the ones that you put your fingertips in and you feel like you're sinking. That is a sign that the connective tissue may not be robust, and that's someone that we look at a little bit more in depth with their management. But that's not many people. That's the exception rather than the rule. Most people really would fit into the stretch rather than the tear, and an acceptable gap, an acceptable function to go off and train. And again, we don't want women to be held back, but we want good function and good technique so that they're doing things without compensating and causing other things. Yeah. Does that make sense?
It absolutely does. And so when it comes to abdominal separation, I feel like we maybe or have already answered this question, but what would be the common misconceptions around it that you come across again and again?
Probably closing the gap is the only thing. That would be the big thing. And that it's pathology. It's not. It's normal to have separation. So it's not a disease. It's not pathology. It's a common thing to happen. It's one of those things that needs to happen to accommodate being pregnant. So it's not unexpected. So they're probably the main things. It's kind of a normal part of pregnancy. It kind of has to happen to some degree. And the focus is not for rehab all about just closing the gap. In fact, you can have a little bit of a gap and it can be completely functional and acceptable and not hold you back with anything you need to do in life. So that's probably the main two messages. Yeah.
I love that, because it is very true. Just because you have the separation, as long as the functionality of it and how your abdominal wall is working and all that type of thing, it doesn't mean that you need to be held back. But I think it's getting to that point that you have the functionality that's really important, and understanding how to breathe, and when it comes to training, making sure that you're breathing in the correct way when you're doing certain exercises to create that functionality, rather than focusing so much on the aesthetic side of it.
Yeah, that's what I'd say that for sure. So that the function and how you're moving and doing the exercises and the activities that you love, versus then focusing just on the aesthetics or just closing the gap.
Amazing. And when it comes to pelvic floor and abdominal separation, especially, I mean, you can't get really past the role of intra-abdominal pressure when it comes to minimizing the impact to both abdominal separation and pelvic floor, especially during pregnancy. Can we talk a little bit about the role of intra-abdominal pressure when it comes to minimizing all that? Especially during pregnancy.
So your pelvic floor and your transverse abdominis and your multifidus and your diaphragm is the canister that controls intra-abdominal pressure. So they work together to be able to almost like disperse and control the pressure, and you want it to be a balanced system. So, you know, so it's done in a nuanced way where no one structure is overloaded. So a good example of it not being well controlled would be if the pelvic floor muscle is weak and distended and a little bit stretched. And so any intra-abdominal pressure kind of goes down, and it can be absorbed in like the viscera and the connective tissue. And that's the pathway towards either incontinence or pelvic organ prolapse. So So that's really important, to get the function back postnatally before patients go off and do, exercises that may really increase intra-abdominal pressure. And for a pelvic floor that's functional, may be absolutely fine and no issues, but for a pelvic floor that may not be fine, could actually create problems like incontinence or prolapse. But also the pelvic floor works in synergy with the transverse abdominis and the multifidus. So they should be synergistic in nature. And again, when they're functional and they haven't been interrupted, they are. And it's not necessarily something that people need to be conscious of. But say that they have been pregnant, they've had a cesarean, they've had a vaginal birth, the synergistic connection and the functionality can be interrupted. So that's where we want to make sure that they've got that deep system in check and working well before they add on the extra loading and really generating stronger pressures. And the most critical phase is really that first 6 weeks, where we want people focusing on that deep system, so that by the time they get to 6, 8, 12 weeks, they're able to start to move up and forward with other exercises that generate higher pressures. And I think for people that are training, like I'm sure you've got clients who will be listening that are personal trainers, so it would be important to be asking questions. Ideally, like you, linking with a pelvic physio, so you've got an understanding about, where they're at and their function is like absolutely ideal. But at a minimum screening, you could use the Australian Pelvic Floor Bother Questionnaire. We could link that in the notes, a modified version. So if you're not comfortable with asking about bladders and bowels and sexual health and prolapse questions, you could just do a screening form. And if they answer yes to anything, you really do need to refer on. And maybe you're the one professional that has asked the right questions and you can lead them in the right direction. And also just asking back after the session, like, did you feel any discomfort in your pelvis, or did you notice that there was any changes in your bladder or your bowel control, or any feelings of heaviness? You can ask questions like that, which gives you insight to whether the pressures were okay or perhaps they were too much, and they do really need to have that internal assessment to figure out what's going on. So I'd say to PTs that are listening, don't be afraid to ask the questions that you need to ask to get the information to tailor the exercise program, or to know that you need to refer on.
I'm going to add a little bit something further to that, actually, because I personally don't believe that as a coach, as strength coaches that work with women in that pregnancy postnatal space, and even coaches that don't necessarily always work in that space. But I think if you're working with women who have had a baby, who are pregnant, who maybe even could be 7 years ago that they had children, but they haven't done any kind of postnatal rehab, they need to be asking the questions. Have you been to see a specialist women's health physio around your pelvic floor post-birth? And I think if the answer is no, I think it's our responsibility to be recommending them and referring them on as like a gold standard part of care, especially if you're going to be putting them under load, if you're going to be putting them under a barbell, if you're going to be loading them with weight, if they've had a baby and they haven't had their pelvic floor checked postnatally, irrespective of birth mode, whether it's been cesarean or vaginal. I think you're actually doing your clients a disservice by not pointing in that direction. That's my opinion.
Yeah, I think it's great, Temi. I think you've always been so tuned in to the importance and the role of the pelvic floor in and amongst, and how that informs the choices that you make in the training environment. And I think you've done such a good job at like highlighting and building awareness and building the bridges between almost the professions, so that we are like working together to make sure that at the end of the day, the person can continue to exercise, but in a way that doesn't compromise their pelvic health. So I think, that's a fantastic approach. And I really admire how you encourage others to really take that on as like standard practice. And the reality is your clients will appreciate it. I mean, hopefully they take you up on the recommendation, but even if they didn't, and that something happened to their pelvic floor, they will remember that you at least tried to get them there. and that you knew that they should, and they knew that they should have as well. And I think that is really important. Even if they don't take your recommendation up, they know that you said something, you know, they know that you knew that they needed to. And that, yeah.
What are the statistics of women, senior women who have pelvic floor dysfunction or urinary incontinence? I think from my knowledge, one of the largest driving factors of women going into aged care is urinary incontinence.
That's right. So it's the second most common reason for people to be admitted to nursing home care is urinary or fecal incontinence. And again, the tragedy is if we did preventative healthcare, like that statistic wouldn't be there. So yeah, the statistics are big. It's 1 in 2 Australian women will have some form of pelvic floor dysfunction over the age of 50 or 60. So that group of symptoms are either urinary incontinence, which is the most common. So leaking with either coughing, sneezing, laughing, or rushing to get to the toilet. Pelvic organ prolapse, feeling of heaviness or bulge, or fecal incontinence, which is not controlling wind, or smearing or soiling the underwear. Yeah, they're far more common than what people realize. So the more people understand that, the more they should actually be thinking, we really can't assume that they don't. In fact, we should be assuming they probably would have one of these symptoms. And let's be the person that asks and guides them to where, because the research tells us that the reason people don't ask is because they don't know, they don't have the knowledge, and they can't see it. You know, pelvic floor dysfunction is not like wearing a knee brace and you're like, oh, you got a dodgy knee. Like, it's not like that. It's silent. There's stigma. People often not say anything. But now people know, then they've got, I'd say an obligation to ask. That's a good way of putting it, having that extra care and responsibility. And then the next step that people have as a barrier is not knowing what to do with the information. So if your client says, yes, I actually do wet my pants, thanks for asking, people don't feel very comfortable if they don't have a referral pathway, because they know they can't do anything about it. But then it would be really looking at your networks and going, okay, who can I reach out to? Just like you've done such a great job of networking with your professional network, then you can say, great, I've got the right person or the right clinic to send you to. That's really the kind of the chain of events that need to happen. Understand that it's really common, not normal. It needs to be investigated, and knowing what to do when your client says, yes, actually, I do have a problem there.
Yeah, amazing. But it all really stems from the pregnancy. I mean, most of it, I think, most of this issue stems from the pregnancy and birth path.
That's right. 50% of it from pregnancy, 50% from mode of delivery, and then there's some other factors that will influence, like lifestyle things like constipation, aging, menopause,
obesity.
Yep, that's right. Chronic heavy lifting in workplaces. But yeah, the big ticket item is that pregnancy and birth, but not just birth, pregnancy and birth.
So I really want to talk around the birth. And, I'm a massive advocate for I think every single woman who has not elected to have a C-section, whether it's medically necessary or they're selecting to do it, if there is any kind of sign that the birth is going to be vaginal, I definitely think that they should be going to a specialist women's health physio and doing birth prep. And I know, this is definitely very different from a birthing course at the hospital. So can you talk us through what birth prep with a specialist women's health physio would entail, and how it is different to, say, a birth course at the hospital? Yeah. And why is it important to do both?
Yes. No, that's great. The big difference is with birth prep with a pelvic health physio, suitably trained pelvic health physio, is it's all about preparing the mind and the pelvic floor and the pelvis. So that's our focus. We're not necessarily talking so much about first stage and second stage and medical options, and what happens in the hospital, like all the processes around birth. We do cover some other things around informed choice and risk factors for birth injury, but we're really focused on like preparing the physical component of birth. We're like your birth coach in a way. And the big focus point is that pelvic floor and understanding, where it is, what it does, and then that it needs to stretch. And then the experience of feeling how it feels to stretch beyond its normal length. And then how to facilitate a relaxation response from your mind. And a lot of it is just learning to surrender to strong sensation and learning how to let go and lengthen the tissues with strong sensation. And the stronger the sensation, the more you need to let go. And the communication that happens between the brain and the breath and the pelvic floor is what we're really interested in facilitating this relaxation response. And you could talk through that for hours, but without the physical practice and the experience of that and the learning that goes alongside of that, you may or may not facilitate, change. So that's really the big part. And we know that if we do that well and we get that stretchiness in the pelvic floor and the mind and the body feeling like they know what's going on and they're not feeling fearful because they've got a sense of control and understanding, that the research shows that we reduce the degree of injury. And if you can reduce injury, it means you have more function and you regain control on the other side much faster than with a significant birth injury. So we're looking to minimize injury and maximize recovery and maintain function. And we also know that even if you did have an injury, you recover faster and you feel less pain. So that's really what the birth prep is around. We also talk about birth positioning. So what is best to facilitate the pelvic outlet being opened versus closed, and some more options around pain management. So using things like TENS machines and vocalizations and different things that can kind of just add into the toolkit. So in essence, women are walking in empowered with knowledge and skills and confidence that they're like, I've got this, versus I haven't really known anything about how to manage my body. I don't really understand what's going on. I've sort of had my head in the sand because I didn't know that was important. And then turning up on game day and going, what is this? It's the wrong time, and to not know. And we prepare for so many other things. Like you think about preparing for the baby room or the baby shower or the, whatever other celebrations that are gorgeous to have around the baby. But, physical preparation's got to be held at a pretty high level in terms of priorities, in terms of how important it is and how it changes the experience. So that's what birth prep is all about and how it's different. It's really the physicality and the skill set and the knowledge to turn up on game day and go, okay, I've got a sense of what's happening and what I need to do to facilitate this.
Amazing. And I definitely, there's that psychological aspect to it as well that I absolutely love. And it's interesting because I spoke to a perinatal mental health specialist the other day, and she was talking a lot about the surrendering and being able to be okay, like sitting in the unknown and the discomfort and all that type of thing, and that how crucial that is for birthing and doing the psychological prep before. So it's almost like hand in hand, right? And I know, I mean, you guys have a program, don't you? Like it's Bump Birth and Beyond. Is that correct?
So I mean, I'm in my 18th year of the clinic. So over that time, we've learned a lot about, I guess, standard practice in the hospital and where the gaps are, and our patients' experiences have taught us so much about what we could have done better if we could have caught people earlier. And so over that time, we thought, okay, what is our blue sky program? What if we had the ability to do it right from the very beginning? What would that look like? So Bump Birth and Beyond is that. It's our blue sky program to really optimize the woman's journey from the moment she's pregnant to the moment she's finished that journey and she's off into other areas of her life. So the principles are to empower her with knowledge, so she knows what's going on at each stage and she knows what to do to make decisions that facilitate best outcomes. Exercise, and so that's where we'd link up with you to make sure that people are actually exercising adequately, because it's such a big thing in terms of health outcomes. So strong advocates for exercise. And then we also look at physio-led exercise, physio-led management. So all about the pelvic floor and at the different stages. And education. So at every point she kind of knows what's going on. So, you know, it's a combination of one-on-one. It's always facilitated by a physio that walks the journey with her the whole path.
That's amazing. So they get this, that's beautiful. Yeah.
Yeah. And then pregnancy, sort of sort out all the things that need to happen, and lots of birth prep to make sure she's armed and ready and able to surrender and let go and lengthen that pelvic floor. We do this great 2-week telehealth birth check-in, which we absolutely adore. Being able to like get in early and find out the birth story and guide if there has been problems, how to manage it early, or if it's a celebration that's all gone really well, to just remind her that she's still healing and to not get too excited too soon and really focus on that pelvic floor and look after her bowels and all the things that people need to do in that early stage, and that physical check at 6 weeks to really make sure that we know what's happened and what needs to happen to move forward to the next stage. So that's the idea of Bump Birth and Beyond. And our observation is that women do much better with that more preventative healthcare. We're not seeing so much trauma and injury if we're getting it right from the start.
That sounds gold standard to
gold
me.
Standard. That's what we're doing.
It sounds absolutely gold standard. And you know me, I always encourage almost that type of stages when it comes to pregnancy. And we're talking about the 6 week, and I love the idea of that 2-week check-in postnatal. I mean, that's unbelievable, because, you know, I think we're both probably very aligned when it comes to the thought process that the 6-week check just isn't really enough. And, you know, I mean, I feel like you've already answered this, because that sounds pretty gold standard to me, but like, what would the gold standard of the postnatal check be for you? Would it be the 2 weeks and then the 6 weeks? And
yeah, so I think it's like before she goes in, we talk to her about how to manage 0 to 2 weeks. So say it's going to be a vaginal birth, we talk about that, and if it's a cesarean, we talk about that. So she's already knowing what needs to happen for 0 to 2 weeks. And then the 2-week telehealth check-in is the birth story. So tell me what's happened, you know, and we screen for bladder, bowel, prolapse, you know, psychological distress and trauma. And then we get to guide on the management, and to make sure she knows that she's supported and she's got the resources to more skillfully manage from 2 to 6 weeks. Because 6 weeks is a long time, and it really breaks your heart when they come in at 6 weeks and they've had this big trauma or injury or distressing situation, and you're like, oh, if only I spoke to you earlier. So the 2 weeks is sort of the check-in, the birth story, the guidance, the support, the resources pertaining to her experience, so she knows what to do, and some exercise guidance and a reminder to keep it low pressure at that point. And then the 6 weeks is the physical examination. So how much things have stretched, how much functions come back, if there's a need for more support, what does she need to do with her abdominals, and what level can she go back to with exercise at that particular point. So it's just the idea is it's just a continuation and a nuance and a guide, and a tweak. So it feels like a very continuous process, that you've got that physio guiding you at every step of the way. Yeah.
I love that. And I love the opportunity to share the birth story so early, because I think that is so important, especially if the birth hasn't gone to plan or the way that they would have liked it to, you know, because I think that can, you know, like, people have certain ways that they want things to go, and when they don't go that way, there can be some kind of disappointment that they need to work through. I think that's probably the nicest way that I can say that. And I am conscious of time, because I don't want to like hold you up, and I've got a couple more questions, if that's okay. Now, there's a couple of them around the fact that we're seeing more hypertonic pelvic floors. So, is it true that we are seeing more women present with hypertonic pelvic floors? And do you think that this is playing into the increase in emergency C-section deliveries? Women that have hypertonic pelvic floors but weren't aware of it.
Mm. Yes. So, goodness, couldn't say for sure whether it links into emergency C-section. However, having a very tight, non-relaxing pelvic floor certainly won't be helping the birth process, given what we've already talked about. So maybe, and there hasn't been enough research that's looked into that. I think certainly people are presenting earlier with overactive pelvic floors because they understand a little bit more, and I think people are more aware of the signs and the symptoms. It's not great. We still see people present far too late with signs and symptoms of pelvic floor that is non-relaxing and too tight. But thing like, for example, I'd say everyone would agree the last couple.
Angela, I'm so sorry. My leg is cramping.
Oh, that's okay. Talking about hypertonic pelvic floors, it's going out in sympathy. It's an emotional first responder. So I think everyone can understand that the last couple of years have been pretty stressful with all the different changes that have happened around COVID and whatnot. So just to give you an understanding is that as soon as there's fear, worry, or concern, your pelvic floor is primed to contract. It happens before you even realize. So the muscles that go on are upper traps and pelvic floor. So that's big, and that has been a significant driver of, I think, people with pelvic floor muscle tone and tension. There's a very much a mind-body connection there. And I think people's understanding around endometriosis and painful periods, and that there's an association with pelvic floor tension. So I think, yeah, there's a few reasons why there is possibly more people seeking healthcare because they're understanding, but potentially there is more prevalence based on, I guess, the lifestyles that we're living, and they're not necessarily the most relaxed lifestyles. And the pelvic floor kind of is a little bit of a barometer of our nervous system. So if we're up-regulated and vigilant and in a high stress state, our pelvic floor will be doing exactly the same.
And that's extremely interesting that I just had that. And just do you know what, I have one last question for you, if that's okay, and that would be, what's the one thing that you wish women knew before they had a baby?
Oh gosh, I'd have to say it's the pelvic floor. Know what it is, what it does, and how to facilitate its function during pregnancy, during birth, and recovery. And if we get that part right, we know that she does better from that point onwards. So I'd have to say knowledge of the pelvic floor.
Amazing. Because there's definitely the mental health aspect that we haven't touched on. And I absolutely know how impactful on mental health birth trauma is. And for women that are suffering from pelvic organ prolapse of any kind of variation, and the effect that it has on their mental health. And I know that you talk a lot about the psychosocial aspect of pelvic health and the stress and that type of thing. Can we speak to that a little bit, if that's okay with you?
Yeah, that's fine. Yeah, happy to do that. So yeah, I mean, birth trauma, it's like one in three women will identify in having a traumatic birth. So it's pretty common. I would like to think our Bump Birth and Beyond community is much better than that because of the reasons we've talked about, empowering people with the knowledge so they can understand and skillfully manage and feel more in control. I think that's a big thing. And then in terms of like the management, so we have a biopsychosocial framework. So, you really need to understand the whole picture. And so screening for things like stress, anxiety, depression, or trauma, past traumas, recent traumas, is just so important, because if those things are the driver to the pattern of the pelvic floor tension, you have to address that. If that's happening and you're just looking at the pelvic floor, it's just going to keep winding up. So perhaps if people are listening to that and they've had the same pattern going on for so long and they haven't looked at the broader nature and the contributors to the patterning, it may give you clues in why potentially things haven't changed. And just remember, the pelvic floor is a first responder to emotional distress, and it is often the barometer of the nervous system. So if you've had birth trauma and you are feeling very vulnerable and a bit broken, that's how people will often say, I feel vulnerable and broken, and I feel like my body let me down. They're big feelings, and you protect your pelvis because of that like framework that your body's working within. And it makes total sense that your pelvic floor is held under chronic tension because there's a protective response because you're not feeling safe. It's the same with sexual abuse trauma. It will be a very, very similar patterning in the pelvic floor. So things like sexual pain or not being able to have sex because it's too tight, they're things that definitely happen. But the important thing is not looking just at the muscle tension. You have to look at the drivers and the psychological components to why that pelvic floor may be chronically behaving like that. Yeah.
And there is a connection between the jaw and the pelvic floor as well, isn't there?
Yeah, so they'll often reflect the same holding pattern. So in birth, they'll say open jaw, open floor. So, they'll talk about deep guttural noises and letting the jaw drop and open and having that response in the pelvic floor. And opposite, like if you're screeching and your jaw's tight and you're making high-pitched noises, your pelvic floor goes up with it. So yeah, the jaw, the voice, the diaphragm, and the pelvic floor all have a relationship. So you can almost sometimes hear the pitch of the voice with the pelvic floor tone. So it's the interconnectedness of the nervous system, the brain, and the diaphragms in the body. Yeah,
it's amazing, isn't it? And I think you really do need the help of professionals to help you decipher all of this. It's not information that even someone that's extremely in tune with their body, all of these types of things, they're not things that we can just know and understand. We really need the help of I believe we really need the help of professionals like yourself to help us decode, decipher everything that's going on and help us through this stage.
Yeah,
so
I think that's right. Yeah, and we're here to do that and to help women feel empowered with that knowledge. So that's the point, to almost use us to know more, to do better, and to, if you fall a little bit, like, you use us to bounce you back up with anything to do with pelvic health. We're like your pelvic health coach. That's really what we're the voice of your pelvic floor.
Amazing. And I won't keep you any longer. You have every time I speak to you, it's like this fountain of knowledge that I'm just like soaking up like a sponge. So thank you so
my
much
pleasure.
for your time today.
I love
really,
chatting
really
with you.
appreciate it.
Thank you for having me.
Yeah, and I look forward to speaking with you really soon. And if you're hearing this message, I want to say a huge thank you, because it means that you've listened to this entire episode. Of course, if you have any questions about the things that we covered in this episode, or want to know more about me or my other projects, you can find me on YouTube and Instagram at The Pregnancy Process. For those currently in their conception or pregnancy journey, you can actually apply to join my complimentary but private community, the Preggy Training Crew. And you'll find my community application and social media links in the episode description. And of course, if you enjoyed this episode, I absolutely encourage you to share it with other women just like you. And I look forward to seeing you in the next episode.